Dr. Seth, you are most welcome.
Thank you so much, Mr. Kamara Daniel, and our dear listeners. Thank you for having me today, and I'll be glad to talk about diabetes today.
Thank you so much. You sound so sharp.
By nature.
So sharp. And I'm
nature,
very much
thank you.
excited, of course, to have you as my OB, as a friend, as a doctor, and of course in all spheres that you're in. And of course for the period of time that you've seen patients, we really want to learn more about diabetes. Please carry on. Teach us about what diabetes is. Give us a brief overview about diabetes. Then we shall go to the other discussion points.
Thank you so much. Once again, dear viewers, I want to thank Gogude TV for the opportunity to host me today to specifically talk about diabetes mellitus, especially in the Diabetes Mellitus Awareness Month.
Yes.
Worldwide, actually. So diabetes mellitus, actually, it's something that is really a topic of interest because it has been on the rise. Because of the nature. Later on we are going to talk about risk factors and how we can prevent. But to put it forward, diabetes mellitus is a chronic metabolic disorder. I want you to mark the term chronic. A chronic metabolic disorder that resides from either two things. One, it resides from either the pancreas. We have some organ called the pancreas in the body not being able to produce enough insulin, or not producing insulin at all, or it can also result from, it can produce insulin that is enough, but the body does not respond to it, what we call insulin resistance. And of course, statistically, it is estimated that about 489 million people are living with diabetes worldwide. That is 1 in 9 people living, and the burden is even more distributed to low resource income countries,
the sub-Saharan region,
where our country, Uganda, is among. In Uganda, it is estimated that 3 in 4 people living in with diabetes mellitus do not know their status, so they present later on with complications. That is the brief statistics that I can give about diabetes mellitus, and it is very overwhelming. So people need to really know that they screen more, because when we talk about the presentation later on, we shall see that actually you can live on, diabetes can live with you, especially type 2. You can go on while it is destroying your organs, and you come to know later on. So it is very important that people screen before it is too late. Thank you so much.
Excellent. Thank you so much. And of course, the statistics really, I often tell Ugandans that statistics are numbers. True. But when we say that 3 in 4, we count ourselves. Like, for example, here, we are 5 already. You know, 3 in 4 of us are not aware of the statistics. And of course, all this comes back to us. And of course, our viewers today will be able to learn more about what diabetes is, and of course, at risk of getting diabetes and a few causes. And of course, you can go ahead and join our social media platforms, Good Television, LinkedIn, TikTok, Facebook, and of course, X, the former called Twitter, so that we can learn and hear from your side about what diabetes really means to you. And of course, this very important year theme is about workplaces, because we've seen very many people in different workplaces are not taking care of themselves. Now, Dr. Seth, kindly carry on telling us about why diabetes has increased, stressing the risk factors, and then later we shall go into signs and symptoms, deeply dive into it.
Thank you so much once again. It's a good question. Why is diabetes on the rise? One, I need to tackle it in the way of risk factors. What are the risk factors for diabetes mellitus? We categorize them into two. We have what we call modifiable versus non-modifiable risk factors. What I mean by modifiable, it is that you can actually do something about these risk factors.
You have control over.
We have control over. And these mainly come from our lifestyles. So diet is number one. Obesity. We have what we call metabolic syndrome X. X in a way that we have 4 things that usually move almost cross. If you have obesity, it predisposes you to almost every other disease. Hypertension, diabetes, then hyperlipidemias. So that categorizes metabolic syndrome X.
Okay.
So obesity being one of the modifiable risk factors. Okay? Alcohol intake. Actually, alcohol has also been found to be related to some kind of type of diabetes mellitus. Because it destroyed some cells in the pancreas that we call the islets of Langerhans, which produce the very cell that some subtype of which produce insulin hormone, the very hormone that is responsible for regulating our blood glucose sugars. So alcohol intake, which can be also modifiable. Smoking, okay? Inactivity, meaning sedentary lifestyle, is also another risk factor that can be modified.
What are some of those sedentary lifestyle behaviors that you do want to cite out?
Okay, some of the sedentary lifestyle behaviors that I would like to cite out is the one that comes really at the topmost is lack of physical activity, what I can call physical inactivity. In that you find that the nature, people at least should at least do at least a simple walk. When we talk of physical exercise, we don't mean that you need to go to gym, but a simple walk, just having at least a 15-minute walk every day can save you from calling you that you are living a sedentary lifestyle. Okay. Because actually, science has it that a 15-minute walk is equivalent to insulin shot for 24 hours.
Wow.
You understand what that means? That means that because the science behind that is that active muscles do not require insulin to pump glucose into the cells. So it is a saving factor.
Okay. So
it is very important that people should understand that physical activity will really help them from almost the non-communicable diseases. Okay. So one of the, if I can just recite one more modifiable risk factor, please physical inactivity would be on top. So dear listeners, please, I call upon all of you to try to live at least a life that can be non-sedentary. Okay? Try some physical activity. So another risk, a modifiable risk factor is stress. Okay? You can modify stress, and it has been related also to increasing what? The risk of having diabetes mellitus. Okay. Then another classification of the risk factors are what we call the non-modifiable. Yes, please. Unfortunately, we can't do anything about that. So we have age. Okay, age has been associated with diabetes mellitus. Race cannot be modified. Okay,
you are either an African.
You are either an African. Okay.
Or you're white.
Then family history of diabetes mellitus. You cannot modify family history. And then we also have genetics.
Kind of explain about family history and genetics, because most people really want to learn about what family history is all about and the genetics. Because now we have the epigenetics. People have really tried to relate to their familial histories, but it does not come out clearly. Good. So you kind of use this chance to tell us more about that one.
Thank you so much once again. So family history, what we mean by family history, and this is where I really need to call upon Ugandans, because it is a very important risk factor, even though it is not modifiable. But knowing that in my family, there is already a risk because there are what we call HLA genes. If we do phenotypical typing, actually now we are glad that Saba-Lancet Uganda can do phenotypical. You can go and do your phenotypical typing and know that I'm at risk of getting this. Maybe you can be the first one to know that in our family there is this gene that predisposes me to getting a certain disease. Okay? And I want to re-echo this, that genetics must have a play. You get? Genetics must have a play with environmental factors for the disease to be phenotypically true.
Explain about that locally. That's a lot of English.
Yeah. What I'm trying to mean is
science, actually.
What I try to mean is, if you have a family history of diabetes, it increases the risk of you getting diabetes. It already means that maybe your genes or your body is at a risk of getting insulin resistance. You might produce insulin, but the cells are not responding. But that one is increased. The risk is increased by physical inactivity, the modifiable risk factors. So someone knowing that in my family there is already a history of getting diabetes does not translate that you must get diabetes mellitus. That's what I'm trying to mean.
Okay, that means that some can go ahead and get the diabetes, and
Yes.
some can go ahead and not get it.
Yes, and it is important to know that if you fight the environmental factors, you will just mask the familial gene that you are at risk of getting diabetes mellitus. That's why some people can be, not every obese patient will get diabetes, because they can be protected by genes that they are not at risk of getting diabetes mellitus. Okay?
So what are those environmental factors?
So environmental factors are the same that I said, that are modifiable. Obesity
alcohol,
being
smoking.
really number one, smoking, alcohol, physical inactivity, hyperlipidemias, having a lot of cholesterol, which is linked to insulin resistance. Okay? And then I was still telling you about relating family history with genetics. So it is very important that people note that having a family history, okay, helps you know that I need to take care of myself environmentally. I need to live a physical activity lifestyle. I need to ensure that I do what? I need to ensure that I monitor my diet, okay, and my ways of feeding. Thank you so much.
Wow. Thank you so much, Dr. Seth. And of course, we are trying to still explore more about diabetes, and of course, learn about diabetes the more. And we are still having Dr. Tukashava Seth, who is a medical doctor and still sharing with us very important aspects when it comes to lifestyle. And of course, now we've explored more of the risk factors. But we have very many myths that many people maybe believe that they have predisposed them to getting diabetes, like maybe if you ate too calories of sugar, if maybe you I don't know, if you slept with somebody with diabetes. Can you sleep with somebody with diabetes if you know? If it is you, doctor. I don't know. But we are trying now to look out for some common myths in the society. Please share some to the
Thank you so
viewers.
much. And indeed, I've listened to very many people come with very many misconceptions. So it's an opportunity to demystify these myths that are out there. There are very many, there are quite many myths that I've heard. One, the first and foremost, people say that when you eat too much sugar, you develop diabetes. So you find someone, when you tell someone that, hey, you have, but I don't take sugar in tea. Okay, it's a very common myth.
Give us now the real information.
I want to really explain
sugar.
this, okay?
Please do.
So really taking too much sugar does not directly translate to you having diabetes. What it predisposes you to is a risk factor that we talked about, obesity, okay? So if you eat too much sugar, it will translate to obesity, which is a common risk factor for developing diabetes mellitus. But it does not necessarily translate to diabetes mellitus. That is myth number one. Myth number two, say that only big people, obese people, are at risk of developing diabetes mellitus, which is not true.
Wrong.
Whereas obese people, like we say, that high risk factor, but also slim people can get diabetes, especially type 1 diabetes. Okay? Hope we shall talk about the types. So, though you can even be slim, but you are living a lifestyle that is poor lifestyle in means of sedentary lifestyle, poor diet, sedentary lifestyle, okay? Smoking, taking alcohol, so you are still at risk of developing diabetes mellitus. That is also a misconception that I would wish to demystify. Another one that I've also heard quite common is that people think that once you start insulin, those who are already sick, that you will be on insulin forever. That's also not true. Okay? Because, for example, for type 2 diabetes, we usually start with oral, but in some temporary conditions, like acute illness or during pregnancy, we can use insulin for the short while, but once the sugars are well controlled, you can also transit back to oral medications for diabetes. So it's also a common myth. So it becomes hard when they come to the hospital during severe illness. We want to control sugars properly with insulin rather than orals. But it becomes hard because people think that once you give them insulin, then they will not be able to take orals. Okay? Another one, people think that taking herbs cure
like herbs.
diabetes. Okay?
But because they will hear from the community, they say, by the way, my aunt had it. She's
Okay.
not the one who's giving the story. Okay, it is not me. Maybe my uncle had diabetes. And he was given herbal medicine and was helped.
No, it's a poor misconception. What herbs can do, one, I want to really tell people that we as doctors, as healthcare professionals, we do not recommend herbs. Whereas they have active substance, but we cannot quantify the doses. We have actually seen very many people come with liver disease,
Kidney failure.
kidney failure. There's a lot of chronic use of herbal medications. Whereas they can control symptoms, we really cannot tell because a lot of studies have not been made about what? Herbal medications, okay? So it's totally a misconception that some herbs cure diabetes mellitus. As a matter of fact, diabetes mellitus, up to date, we have not got the cure. Though it can be complete cure, whereas we can completely manage it, okay? Another misconception that is also very common about diabetes mellitus is that when you are feeling fine, especially for people who are already diabetic, they have this misconception that when they are feeling fine, totally fine, then they have been healed of diabetes. Or when they check their sugar and they find it is within normal, that they are completely healed of sugar. The truth is, diabetes, it can go on to destroy literally every organ. It can destroy literally every organ. It can give you stroke, it can destroy the eyes, it can destroy the heart, it can destroy the kidneys when you are totally fine. So it is very, very important that once you have been diagnosed with diabetes, you just follow your healthcare providers' guidelines and ensure you adhere to your medications. So those are some of the misconceptions that I would love to demystify today. Thank you so much.
Wow, wow. And of course, these are the most common myths and misconceptions that are common in Uganda. And of course, we'd like once again to inform our viewers that this is Health and Beauty program. We are focusing on diabetes, chetuita mu Luganda sukari. And of course, we are trying to learn more about it and of course, what the community tells us versus what we face in the real health practice. Dr. Seth, do you have any experience with a patient with diabetes you'd like to share?
Automatically.
Please go ahead and share.
Automatically. Like I've said, it is now a chronic. It's like a new cancer. And ideally, just last week, I met a young man, 25 years, who came in with just numbness. Just numbness. Okay? And that's how this is very important because people need to know that they really need to screen. Because many people are really living a sedentary lifestyle. They are living a life that predisposes them to diabetes. So this young man was having numbness, and we know, let me use this chance to explain how diabetes also presents. Okay?
Please do.
Yeah, because presentation of diabetes mellitus, I want to say that it is heterogeneous. I might be using the most scientific, but I would beg to also ensure that I break them down.
Please do.
Meaning that the way you present with diabetes might not be the same way I present with diabetes. And that said, I want to also say that you can actually be totally asymptomatic. The way I'm with you and you are living with diabetes, especially type 2 diabetes mellitus. Okay? So, you waiting for symptoms to suffice might be too late. Because on average, for someone with type 2 diabetes mellitus, the typical presentation, which we actually call in our language the 4 Ps, where we have polydipsia, someone have increased thirst every other time. Okay?
Water does not help.
Water does not help, and it's because of the osmotic diuresis. When you have too much sugar and you are losing it on the kidneys, it draws water with it. The term we call osmotic diuresis, and it predisposes them, it makes them take more water. And that occurs because the level at which, because the kidneys initially are supposed to be reabsorbing glucose, but they have a threshold, which is at 12. So when the sugars are above that, then you lose glucose in urine, and water is drawn across. So it predisposes people, the thirst system will be activated, and you want to take more water. So we call it polydipsia. That is 1 P, the typical. Another one is polyphagia. People want to eat more and more, and I've seen very many people come with that.
More frequent times.
More frequent times, and when they eat, they're not adding on weight. Because as we said in the beginning that the main problem is lack of insulin, or you have insulin, but it is not being responsive, it is not working.
It is not
The receptors are not working. So how polyphagia comes about is that one of the primary roles of insulin is when you eat food, Mr. Kamala Daniel, now, your insulin will help store that food into the liver in form of glycogen. And during hunger time, when you have not eaten, for example, I've not yet eaten, this morning I've been busy, but I'm surviving on the stores that my insulin used yesterday night, store glucose. And that's why even when we are managing diabetes, we encourage them to eat small, frequent meals. Because it is a derangement that they have, that now insulin is not working. So you do not store, you don't have something you have stored for future use, for fasting time. So these people will present with polyphagia on top of polydipsia. So they want to eat and they are not adding on weight, and there is weight loss. Okay? Then another common presentation is what we call polyuria. Okay? Increased urination every now and then, and I've explained that. The moment you have glucose lost at the kidneys, it will draw water with it by osmosis, and you will have to do what? Then another P, you want to over-urinate. And then others, it is a result of microvascular complication of diabetes. They usually get numbness, so the nerves have been affected. Okay? So we usually describe them as pins and needles. You have feeling of as if some things are, you have pins and needles in the hands, especially the symmetrical, the extremities. Okay? So, of course, on top of that, some other people can come in complications of diabetes. Someone can come because of kidney failure. Tracing backwards, have diabetes and has been undiagnosed for long. Some can come in what we call diabetic ketoacidosis, in coma. Okay? Especially when they have diabetes and then they get like an infection on top of that.
Okay.
And we diagnose them then. Okay? I've seen people where we have diagnosed with what we call hyposmolar state. So where you find that because of too much glucose, it increases the osmolarity and it doesn't balance with the brain. So they go into coma. So you can just imagine someone coming in coma, but the cause is undiagnosed diabetes. So it stresses the fact that people should do more of screening than waiting for symptoms to surface. Okay?
Wow.
And the case in point that I was saying, this young man that I met, 29 years, with just numbness. Only numbness was the presenting complaint. That was diabetic. Okay?
And he was not aware.
And so it was just only the P, okay? The one P among the many of having nerve defects, okay? That was presenting. So if he had missed that, okay, probably we are lucky that his kidneys were still fine and has been started on treatment and is now doing well. So it is very, very important that Ugandans should do more of the screening.
According to your history, what do you think made him get diabetes?
Good question. So for 29 years, we really had to take a good history to find out why. Okay? And among one of the major risk factors that we found out was this young man has been taking a lot of sodas. Okay? He admitted that for the past 2 years, he has been taking at least 3 sodas in 1 week. And I want to stress this out to the dear viewers that one bottle of soda, just one bottle of soda, is equivalent to 3 plates of what? Of posho. So that is too much glucose. Like I said, taking too much sugar does not necessarily make you, but it increases the risk factor. So he was a young man who is obese, and he also got hyperlipidemia, had a lot of bad fat, cholesterol, which predisposed him and later on resulted into insulin resistance. So for his case, it is type 2 diabetes mellitus. He can produce insulin, his pancreas is fine, but it is not working. The fats have clogged the receptors, so that's why he's presenting like that.
Wow. Then according to your examination, don't you think he's at risk of getting the complications?
Like I've said, the good news is whenever we diagnose diabetes, especially type 2, because like I said, on average, it has been found out that you can live with diabetes for approximately 5 years when it is destroying your organs. And then that overt presentation comes later on. For this young lucky man, so whenever we have a diagnosis of type 2 diabetes mellitus, The ideal is you should investigate for complications.
Okay.
Because one of your goals of management of diabetes is, number one, to control, because it is not curable. But number two is to delay
The development of complications.
development of complications. And number three is to manage already existing complications. That is if at all they are manageable. Okay?
I am interested in hearing about the social history
Okay?
because it determines what actually the person
very,
is.
very important.
So tell me about the social history.
Okay. The social history, obviously, like we say, was a smoker, he was an alcoholic. So you can see all these increase the risk factor of this young man, on top of having a sedentary lifestyle. And there is no family history of diabetes.
Very
Okay?
important to know.
So it is very important to know that you can actually develop diabetes just by the risk factors that are only modifiable. Only modifiable.
what was his job?
He's a businessman downtown, okay? Okay? So it is very important to dear listeners that we actually focus more on controlling the modifiables.
Wow, very important discussion scenario here with Dr. Seth, and of course, it is not a ground round, but we're trying to learn more about, in cases of persons who develop diabetes, and of course, trying to rule out the key 4 P's he talked about. But of course, this very important man presented with 1 P, which was actually pins and needles. And doctors fully explained to us, according the history and the social history, all this is very important for you to tell what the actual problem is. And of course, we're going for a short quick break, but when we return we shall discuss more about diabetes in bid to raise Ugandans about screening, awareness, but of course calling upon individuals, households and communities to be fully aware so that they can promote self-care within their household. See you shortly.
Near stagnant water and mosquito breeding sites, malaria lurks, always waiting to strike. But fear not, for here comes Mr. Vaxa, the ultimate protector against malaria. For years, malaria has been one of the biggest threats to children under 5, making them weak and even putting their lives at risk. But now, the government is introducing a new solution, the malaria vaccine. The malaria vaccine is now in the routine immunization schedule. The malaria vaccine is administered in 4 doses at 6 months, 7 months, 8 months, and 18 months. This vaccine will provide extra protection against severe malaria. And don't forget, routine immunization protects children from many deadly diseases. Every vaccine matters. Visit the nearest health facility for routine immunization services today. Mr. Vaxa, the malaria vaccine is free, safe, and ready to protect our children. Will you join the fight and complete all 4 doses? For more information, call the Ministry of Health on 0800 100 066. This message is brought to you by the Ministry of Health.
For being a good viewer of Google Data Vision, we are located at Sapro Kagwa Road at Makefro Gospel Church. Just like we have very many programs on this important station, we encourage you to always tune in, learn about the Christian lifestyle and get saved, because remember, in the long run we shall leave this world and we shall go to eternity. And remember to prepare your slot in heaven. I usually want to echo this because when you are saved, you live with faith, you live with hope, And that's the assurance of the future. Once again, we are talking about diabetes, and I am still joined by Dr. Seth Tukashava. And he's a very, very good, actually, young doctor who is passionate about non-communicable diseases, and so far talked about very many things. And you're a young doctor, or you're an old person?
Yes, I am. I'm glad.
So, and of course, we want now to explore some of the classification. Let's talk, because we've seen type 1, we hear about type 5. We'd like to hear about a few classification, what do they mean, and maybe how do we stand in Uganda. Then later we shall explore more of prevention, because the population cannot manage the treatment. I don't know, according to your side, you'll share experience. But of course, our viewers are encouraged highly to visit our social media platforms, Good Television Uganda on LinkedIn, Twitter, Facebook. Share your comments, opinions, and of course, share your comments if you are living with diabetes, if you are living with your history, I mean, your journey living with diabetes empowers other people who are living with diabetes. Peer-to-peer learning is really very important and encouraging to our viewers, but also other people who will be reading the comments. Dr. Seth.
Thank you so much once again. And I have to also again thank our dear listeners for tuning in and being with us up to this far.
Yes,
we can't take it for granted. So the, like you requested, classification is very important, because people need to understand. We have been using type 1, type 2. What do they mean? So generally, we have mainly 3 types of diabetes. We have type 1, okay? Type 2, and then what you call gestational diabetes. Okay. So type 1 literally is, we classify depending on the possible defect. What is wrong? Why are we having diabetes? So in the type 1 diabetes, it is, like I said, diabetes as a result of what? Either the pancreas is not producing insulin at all. So that is type 1. Okay? You have absolute insulin deficiency. That's the right term. You cannot produce any insulin at all. Okay? And I want to say that anyone can get type 1. Okay. And that's why we actually also call it juvenile diabetes mellitus, because even day 1 child can have type 1 diabetes. Okay? It mainly results from autoimmune destruction. Autoimmune means self-destruction. You can have a small viral infection. The body tries to clear it, but it overreacts. And among others, the organ that is destroyed is the endocrine part of the pancreas. To be specific, we have the beta cells of the islets of Langerhans, which produce that insulin. They are destroyed, and you develop type 1 diabetes mellitus. So you have no insulin at all. Okay? So the presentation is overt. When you get it, you develop symptoms there and then. Type 2, whereas, is because of either 2 things. One, you could have relative insulin deficiency. In other words, it is not absolute. You have some small production of insulin, which is not sufficient. Or you actually produce enough insulin. The pancreas is totally fine, but the problem is on resistance. So you have insulin resistance. The receptors are not responding to the insulin produced. And among the risk factors, like I say, hyperlipidemia predisposes to insulin resistance. Okay? And that's the same reason why people who are in pregnancy, it goes to now type 3 gestational diabetes. That during pregnancy, during a certain phase of pregnancy, specifically our 2nd trimester, there is a hormone that is produced. So because of the hormonal effect, okay, there is an increased risk factor of insulin resistance. So some people, especially when they already have a familial history of diabetes, okay, there is more risk of getting insulin resistant during pregnancy, and they get gestational diabetes. To make this clear is, when you have gestational diabetes, you could actually, after pregnancy, because the effect was hormonal, get completely cured, but it predisposes you at a risk of developing type 2 diabetes later in life. Or you could be having diabetes before pregnancy, but you had not screened it. It becomes very overt. It becomes worsened during pregnancy, and we make a typical diagnosis. Okay? But I also want to ensure to know that there are other microtypes of diabetes. Okay? We have what we call bronze diabetes, for example, which is a result of iron overload. When iron goes into the what? You have too much iron, what we call hematochromatosis, in the body, and it also destroys the pancreas. So we call that bronze. But it falls under type 1 because it all goes back to you have no insulin production at all. Also, alcohol alone, okay, can cause pancreatitis, destroy the pancreas, and end up destroying completely the pancreas, and you develop alcohol-related diabetes mellitus. And it will also fall under type 1 because there is no insulin produced at all.
Wow.
So there I think we have at least what we mean when we say this one has type 1 and this one has type 2, because then it guides our management. Okay?
Wow.
Thank you.
Thank you so much. And of course, now we'd like now to highlight a few challenges or complications faced by people who live with diabetes. It is very important for us to have a grand talk about people who are the warriors, people who are living with diabetes. What are some of the challenges they face, and a few complications maybe they should pay attention to, or maybe then later we shall talk about prevention.
Thank you so much. A good question again. What are the challenges that people living with diabetes mellitus face? I think the major challenge is, like I said, diabetes, I must put this clear, is not curable. So just having that alone, the mental stress, I think I would love to, we bear that together. It's not easy to tell you that the disease you have is not curable. But the good news is it is controllable, and the people with diabetes mellitus, if they listen to the healthcare providers, they can actually manage diabetes and live a very productive lifestyle like any other person who does not have diabetes. But among the major issues they have is, of course, having especially type 1, where they have to use insulin every other meal. Okay? So it's a big challenge. And thanks that insulin is readily available, at least that I thank it for the government. It is readily available in hospitals as far as health center falls. So insulin can be got, it is readily available. It is one of those drugs that the government ensure they are not out of stock. Okay? So availability of the drugs are there, but now the burden becomes on every other time. Injecting yourself. And especially another challenge we face is what we call hypoglycemia. When people are on insulin and they don't listen to the healthcare providers to get that very optimal dose, there's a risk of an overdose, and they usually go into low sugars, which is more dangerous than high sugars. So I encourage people who are living with diabetes to ensure they are close, they have a close partnership with healthcare providers to know the right dose of their insulin. Okay? Because hypoglycemia will kill you. Okay? Low sugars, if they go lower to very critical levels, will kill you. And it is usually the most complication of using insulin, though it is manageable. And of course, when we come as diabetes, the complications, there are so many. Okay? I want to again recite that diabetes can affect literally every organ. Okay. That is, if it is not well controlled. Okay? If we say the brain, very many people get stroke because of diabetes. No one wants to get stroke. Okay? It can destroy the heart. Okay? The vessels supplying the heart. The most feared complication is actually what we call diabetic nephropathy, the kidney. Kidney failure is leading #1 death. People with diabetes die mainly from cardiovascular and renal complications. So as day follows night, as you are not controlling your blood sugars, it is destroying your kidneys day by night, day by night. And many people present in end-stage renal failure, where the only solution is dialysis or kidney transplant, of which it is very costly and not readily available in the country. And also the other major complication I've actually seen is diabetic retinopathy. people becoming completely blind from diabetes. Okay? And it is irreversible, meaning that once you have already got that, we cannot do anything as healthcare providers. So the goal is to actually prevent, like I said, when you have diabetes, it doesn't mean you will get that. If you control your sugars well, you either prevent complications or delay, because even diabetic retinopathy has grades, grade 1, grade 2, grade 3, grade 4. So if you find someone on grade 1, you can delay or stop progression to grade 2, grade 3. But unfortunately, if you find someone already at grade 4, then you cannot do anything, and they are completely blind. I'm sure you have seen one that they said diabetes made this person blind.
True.
Then, of course, also among microvascular complications, the smaller nerves, people come with pain. There's sciatica pain. Okay, have too much pain. It's almost uncontrollable because it destroys the nerves. Okay, then of course diabetic foot. One of
What
the
about
common complications. So one thing I want to tell you is that diabetes has both macro versus microvascular complications, and diabetic foot can be also classified. You can have a diabetic patient having a microvascular complication. The nerves have been damaged, that they cannot sense anything. So when they step on, for example, a sharp object, maybe a nail, it will go in them and they will not know. Okay? So you see them, they only realize when they are seeing the leg rotting. Okay? And when they get an infection because of uncontrolled sugars, it is very, very hard to control the sugars. Okay? So diabetes is one of those diseases that cripple the immune system. They do what we call leukocyte syndrome. So in other words, what you have is, when you have an infection, our first line of defense are the white blood cells. But when you are having diabetes, they cause that condition that we call leukocyte syndrome, that they grab. It's like you have you attacked at home, and the first person that the rebels have attacked is your security guard. So that's what diabetes do. They first cripple the body's immune system. That's why when you have infections in diabetes, they just spread uncontrollable because of that phenomenon caused by diabetes.
Okay.
So it is very important that actually people know that diabetes is very dangerous when it is not well controlled.
Okay.
So it is important that they don't fear, they do screening, and when they are told they have diabetes, they also shouldn't fear, but they should embrace, because embracing the reality will help them manage and be able to avoid complications that are fatal. Because all people with diabetes, they don't die because of diabetes, but they die because of complications of diabetes. And also, early detection will also save them from living a poor quality of life as a result of complications of diabetes mellitus. Thank you so much.
Wow, thank you so much, Dr. Sev. Let's explore prevention strategies. Let's explore the prevention strategies, and of course we shall talk about, you talked about treatment, we have few drugs, and of course, let's talk about prevention, then later we call upon the government.
Thank you so much. So for prevention, I will also stress again, it goes to risk factors. Because if you know that this is what causes this, then it is very easy to know that I can do this. So number one, okay, is to be mindful of our diet. Okay? What do I mean by being mindful of our diet? At least have that in mind, that whenever you are eating something, okay, be smart. Okay? And this one I also tell people that whenever they have diabetic people, I think it is another misconception that I forgot. People think that when you are diabetic, you should not eat this, you should not eat that, you should not eat fruits, you should not eat. They ask now, which food should we eat? So having diabetes does not mean leaving food. It's about discipline and eating smart. What do I mean by eating smart? Eat in moderate quantities, whether you are diabetic, whether you are not diabetic, as a preventative strategy. Okay? You should eat more of food that contain antioxidants, vegetables. For those who can afford eating fruits once in a while, eat fruits. Okay? More of the green food, what you call as dear nutritionists. Okay? Then also, you should ensure that you eat less of junk food. we have this cancer of people eating junk food, yet they are living a sedentary lifestyle. Okay? Because like I said, what the body does is try to store and store and store and store. But that's you get in form of lipids and then translate them to low density lipoprotein, cholesterol, which are very bad, which will cause insulin resistance. So to me, the most important message in prevention is diet control and living a healthy lifestyle. Of course, on top of avoiding bad social living styles, behaviors, alcohol intake, smoking, okay? So, and of course, early screening. When you do early screening, and the disease is called early, or we actually have what we call pre-diabetic state. In that, they can screen you today and they say you don't have diabetes, but you have values so that if you continue on this trend, you will actually get over. And at that point, that is where it is completely curable because you can reverse that. So early screening is also a preventative mechanism.
Wow.
And without forgetting that those who are already diabetic, they also have preventative. As we said, you need to prevent complications, already existing complications. So the prevention literally stretches from primary to tertiary prevention. From those who are not yet sick to those who are sick. And even those who are sick with complications, we want to delay further complications. Thank you so much.
Wow. Thank you so much, Dr. Tukashaba. Now, let's explore a few calling remarks to the viewers who are watching us tonight. We want to now call individuals, households, and the government. What's your message to individuals, to the households, the communities watching us, and to the government at last? And also to health workers. We must be having a message to health workers as we intend to rally against diabetes in Uganda. We've been having a conference about unifying actions against communicable and non-communicable diseases, and we saw that every person has a role to play in this. Therefore, I want you to rally your information in the age groups, to the individuals, the households, the communities, then the health providers, then again the government, as we intend to wrap up this discussion.
Thank you so much once again. As we wrap up this discussion, my message to different individuals, okay? One, from what we have heard and what we have learned today, that actually anyone can get diabetes, okay? We have listened to the risk factors. So I call upon everyone, let it be individual role to mind what you eat, because you are what you eat, okay? To mind your social history, okay? To regulate, if possible, avoid bad behaviors, alcohol intake, smoking, and also, of course, to healthcare providers. The message is, please, let's use every encounter with a patient as an opportunity to create awareness, to call for prevention, to call for screening, and to teach those who have diabetes better ways of living and managing their diabetes mellitus. Of course, to the government, to the policymakers, to the people who have people's trust, okay? I would call upon them to increase awareness, look for ways of increasing awareness, because statistically, a study done in 2024, which is just a year ago, found a stretch that 89%, that is almost 3.5 out of 4 people living with type 2 diabetes mellitus are undiagnosed. What that means is we have all the people that are sick are out there and they're not diagnosed, and that comes from people are unaware. And even then, when they come to the hospital and you are diagnosed with them, you see they don't have any information about what? About diabetes. And lack of that information will also translate into non-adherence to drugs. So even when we have found that someone is sick, you have started them on treatment, there is not enough time to actually explain the importance of being on treatment. And this translates into developing complications, even when there has been an opportunity of catching it early enough. So my biggest message and my biggest call would be calling for awareness through different medias, okay? Just like Google TV. I'm very thankful to Google TV for this, because whoever have seen this have taken a message have learned one thing or two, and that one thing or two could be the ones that would be a game changer. So I would call about policymakers to put more into prevention, because treatment is very, very expensive. Very expensive. $1 trillion US statistically is the money spent per year in diagnosis alone. I'm not even talking about treatment. Okay? So, and those who are sick already, they should know that diabetes mellitus is manageable. You can manage diabetes and prevent complications.
Excellent.
Thank you so much.
Excellent, Dr. Tukashaba. This has been a very wonderful discussion. Of course, we believe our viewers have fully learned about what diabetes is. There are few statistics that are very worrying, and when I was sharing a session in Munyonyo of recent, we were talking about the non-communicable diseases, and I told the people who were there that when you are listening to the announcements, so and so announces so and so, so and so, so and so, you are not touched because you do not know them. But when it is in your family, it's when you feel that you've lost someone. Just like statistics, if we said that maybe 2 in 3 are like this, but you are not among them, you feel like, those are numbers. But the moment they say you have the disease and you're part of the big 4, that's how you feel the impact. I'd like to implore you to prevent yourself, just like Doctor has alluded. Before I wrap up this, do you have any greetings? Do you want to greet a few people? Then we can call this discussion closed.
Thank you so much. Of course, I have taken this opportunity to, one, greet my fellow doctors at Chirudu National Referral Hospital. Greet my family, my beloved family, Festo's family, and children. And of course, without forgetting, greet my beloved friend, Princess Hamba Patricia. Thank you so much.
Excellent. I expected here Montiera High School, but you've been marginalized.
Oh, I have to. Montiera High School community, Ntare community. Yeah, I send my greetings.
So thank you so much once again, Dr. Seth, for coming on Google Data Vision Share Expertise. We'd like once again to thank you. And of course, rally Ugandans to take charge of their health. Do not wait for government. That has been my statement, because government comes later. But of course, we want to appreciate the Ministry of Health, because at least 5 kilometers from each home, we have a health facility. So there's no reason of why you're not screening, yet you can also protect your life. I am Kamara Daniel, your health presenter for this very program. See you next Wednesday. Take care of yourself. I hope to see you again. Bye-bye.